please. Welcome to meeting number 3,812 of the College of Complexes, the playground for people who think. Although I am not a capitalist,
They've done that every once in a while.
Tim,
Yeah, I know. It fell. Just keep going.
all right. On April although I'm not a capitalist, I will give an advertisement for our upcoming programs. On April the 12th, we'll start our special Earth Day series of speakers with the Illinois Environmental Council, sending a young man, a representative. It's a collection of over 200 environmental organizations that cooperate together. On April the 19th, yours truly, Charles Padak. Charles Padak will be giving a 15-question quiz in which you can tell by your score is how green a voter you are. How green a voter you are. I give you questions and answers. On April the 26th, Congresswoman Marie Newman, former Congressperson Marie Newman, will be talking about her new book on how to start a movement.
I haven't been drinking
How to start a movement.
at the Lincoln restaurant.
On May the 3rd,
There's a moose head there.
please be quiet in the restaurant. Thank you. On May the 3rd, our own Justin Tucker will be our special May Day speaker. And he will look at the Saul Alinsky's Rules for Radicals
Like Budweiser.
on May the 3rd.
I don't like that. They don't have.
On May the 10th, Eric Moore, political analyst, will be here to talk about a multipolar world.
You got it on microphone?
On May the 17th, we're going to have a return. They haven't been here in quite a while. This is particularly relevant with regard to the tariff. But AMI, the American Monetary Institute, Steve Walsh and others will be speaking on the U.S. and the world economy. On May the 24th, Ted Tesser will be talking about culture wars. How they're trying to defund the National Endowment for the Arts and how they tried to do this once previously. So we're going to talk about culture wars, a hot topic right now. That leaves May the 31st is open. It's open if you'd like to speak. Plus, we have 4 dates in June, 7, 14, 21, and 28, if you'd like to speak. Okay, that's for my announcements. Take it away.
Okay. Hi, everybody. I'm Bill Bianchi. I'm the board chair of Illinois Single Payer Coalition. And we have been working, let's see here. We've been working for single payer for the past since 2008. We're a 501c3. I'm sorry, I have to get one more sheet of paper. I need to say this correctly, otherwise I'll get into trouble. Who's the belief? Okay, the Illinois Single Payer Coalition is a 501c3 nonprofit organization founded in 2008 to work for the enactment of a national improved Medicare for all single payer in this country. We believe healthcare is a universal need and a universal right, not a profit opportunity, as you probably experience it. And that a wealthy nation like the United States has a moral obligation to provide all of its residents with equal access to quality health care, which is what happens in many other wealthy countries. We think the healthcare system should be publicly financed, privately delivered. It should cover everyone cradle to grave with all medically necessary care. And most important thing, free at the point of service. Uses money efficiently and wisely and lets individuals choose their own providers. It also reimburses providers equally for equal care, which is something that does not happen today. So, all right, let's look at today's agenda. I think most of you probably are somewhat familiar with Medicare for All, single payer. Am I wrong about that?
I'm familiar with Medicare.
Well, yeah, Medicare. Okay, that's not what. Well, that's a model. That's a model for what we're talking about. Today in our agenda, though, we're going to talk about the privatization of Medicare as we know it, with Medicare Advantage, and cuts to some Medicaid programs, and why Obamacare did not solve our crisis. And also, I mentioned racial inequity in healthcare and Medicare for All, and how a single payer healthcare system will control costs and fight profiteering better than the private insurers. And then we're going to look at a few campaigns that are going on right now for Medicare for All and to fight the cuts, and then how you can get involved should you care to do that. Before I want to frame this in the things that are going on now. And right now, simplest way to say what's happening right now is an attack on all public programs. Just like we had public parking on our streets, that's been taken away from us. And the money from that goes out of the city. That's what's going to happen on almost everything. They will try to privatize healthcare. They will try to privatize education and make money from it. Put a fee on it. And that's what we have to oppose. So, traditional Medicare and Medicare Advantage. What's the difference? I'm assuming that a lot of you in this room are on Medicare. Am I right? Right now? Not quite yet. All right. So, how do you get your health care coverage?
Obamacare.
Through what?
Obamacare.
Obamacare. Oh, okay. That's interesting.
Was that Medicaid?
I have a job and
Medicaid, right?
You have a what?
I have a job and it's one of the benefits
Oh,
of my
it's
job.
part of the job. But you have to pay for that a little bit.
My employer pays part and I pay part.
And you
So
pay.
it gets, part of it is deducted from my
Okay.
paycheck and part of it is covered by my employer.
All right. So, well, back in 1960s, they passed the Medicare program, which was a health care for seniors. And up until that time, most seniors were reliant on either their savings or their children to take care of them. And there was a lot of poverty among seniors. That's completely changed with Medicare. And at that time, it was a public system. Right now, it's become a private, well, half of it is going to become a private system. But traditional Medicare is a fee for service. You go to the doctor, you get some treatment. The doctor sends a bill to Medicare, and Medicare pays the doctor or the hospital a fee that has been negotiated in advance, by the way. So there's no question about that. So Medicare pays providers directly. Providers cannot charge more than the negotiated amount. So once a provider accepts Medicare, they can then send you a bill for additional amount of money. Medicare Advantage, or what, as we call it, Medicare Disadvantage, is a capitation program, and it pays in. What happens is Medicare pays insurance companies a set fee annually per each enrollee. So, for instance, for Bill Bianchi, if I were on Medicare Advantage, I'm not. I'm on the traditional Medicare. Medicare would send my insurance company, the plan that I signed up for, maybe $10,000 a year. And that the insurance company then would become responsible for all my health care bills for the entire year. So I may have none, in which case they make $10,000, or I may run up $100,000, in which case they lose a lot of money. So there's a risk.
Is that Part B?
Well, that's the whole system. That's the whole thing. It's A, B, and
So Advantage is B, right?
what?
Advantage is B?
Oh, excuse me, I'm sorry, you're right. It's, Advantage is C, I think.
It's Advantage C.
Yeah. Medicare Advantage is C, and when you have that, then they are responsible for paying all your bills, except for the drug plan, which is separate, and that's got to be. So now the problem is the insurance companies are in the business of making money, not necessarily in the business of keeping you healthy. So in order to, what would you say, avoid the risk, they have to find ways to, well, I have to tell you first, how does Medicare for All work? Let's skip that. We'll go to that. So how has this system become privatized? Well, I'm sure you've all, if you're a senior, you've seen a huge number of ads online, on TV, on the radio, in the mail. And they spend billions of dollars promoting Medicare for All. They take advantage of the weakness in traditional Medicare. About half of all Medicare enrollees are now on Medicare Advantage. And states are putting their unionized retirees into privatized Medicare Advantage plans. Why? Because they save money doing that. And so let's move along. So what's wrong with privatized Medicare? Why should you not like that? Well, because they have to control costs, and they do it. They do it with limited networks of doctors and hospitals. So what they do is they go around to doctors and say, we'll give you X number of dollars for this treatment. And it's usually a pretty low price. And the doctor will either accept that or won't accept that. When they have enough doctors and hospitals signed up, they have a network. And then they put you in that network. These are the only providers who will, the insurance companies will pay. So if you go out of the network, what happens?
Not covered.
You got to pay for it yourself out of pocket. And depending, if you're talking about $100 bill, it's not a big deal. But if you're talking about $10,000 bill, it is a big deal. So you're probably going to stay within the network. This also means that some of the best doctors, the ones with big reputations, the best hospitals, they don't have to, they can negotiate higher prices from the insurance companies. So they're often not in the networks. And so you're stuck. For example, I'll give you an example what this means. One of our former board members who lives in the Rockford area, his husband was diagnosed with lung cancer. And they were told that the best place for him to go with his kind of problem would be Mayo. Unfortunately, Mayo is not in the network. It'll never be in the network because it's pretty expensive and it's out of state. So they couldn't go to Mayo until they got rid of Medicare Advantage, went back to traditional Medicare. With traditional Medicare, you can go anywhere in the United States. Oh, you cannot do that with Medicare Advantage. They also use something called prior authorization and denial. Prior authorization means since there's hundreds and hundreds of Medicare Advantage plans, doctors and hospitals can't know what's covered and what's not covered. So what do? They have to call them up and spend an awful lot of time, an awful lot of man and woman hours on the phone talking about this. And then if they don't come to an agreement, what happens is the claim is denied. And denials are an important part of the business plan of private insurance. Hundreds of thousands of claims are denied every year. And when your claim is denied, that means you have to get on the phone and argue with them. And that's a process that takes hours and hours and days. And often you don't get anywhere. In addition to that, they make it hard for you to see specialists by requiring you to go to your primary care provider for a prescription. So if you have a bad knee and your knee is hurting and you want to go to, what are those doctors called? The bone doctors? Or orthopedics or something like that. Yeah, orthopedic doctors. Yeah, orthopedic surgeon or something like that. You can't just go to that person. You have to go to your primary care doctor, get a prescription, and then go to them. What's the point of that? The point of that is to delay. Because of the delay, some people will not follow up and they won't go to the doctor. and the insurance company saves money.
I think it's an advantage to
A little louder, please.
I like having a primary doctor because you see him all the time.
Well, you can still have the primary doctor, but you don't need his,
Get another set of eyeballs. To a specialist, gotta make another appointment.
sure.
The primary checks you out initially. I tore up all my shoulder.
Jake, mute, please.
So the primary saw me about it and
Then he sent you to the specialist.
for, bone and muscle and all that stuff up here. So.
The Canadian system, you have a lot of waiting lines.
Wait,
A lot of
let's go
delays.
at the time he's not done, we'll do a Q&A after.
Okay, I want to see what's going on
Well,
here.
it's fake.
It's all right. You're still recording.
Shall I continue?
Yeah, go ahead.
Okay.
Time, you're not gonna get it.
So delay, deny, and sometimes death is part of the business plan for a lot of insurance companies. Okay, so let's move along. Somebody said they were on Obamacare.
Okay,
You know, it's
hang
been-
on. Charlie, can you see our speaker still? Charlie, can you see our speaker?
Yes, just let them speak.
Okay. Go ahead,
Please
son.
go on.
Somebody said they were on quiet, please.
Wait, are we okay?
Yeah, we're all right.
Yes.
Okay. So it's been 15 years, by the way, since Obamacare was passed. It seems like, just a couple years ago, but no, 15 years ago. And so did it work? I guess that's the question. And the answer to that, I think, is yes and no, depending on how you want to do it. So what are the benefits of Obamacare? Well, the main benefit for most people was the expansion of Medicaid to cover adults without children. So adults who qualify, have a low enough income and qualify for Medicaid. Remember, there's an income requirement. About 6 million of them now have coverage that didn't have coverage before. And that's only in the states that allow the expansion of Medicaid. So that's an important thing, but it didn't have to be part of the ACA. It could have been separate and just done on its own. The next benefit is the near elimination of pre-existing conditions. When I lost my job back in when I was like, I think 60 or 59, well, I didn't lose my job. I mean, the place closed down. So I didn't have coverage, and I was too young for Medicare, so I had to go buy an insurance. So I bought it in a policy, and they told me there's something with these exceptions. And the exceptions were the three things I was most likely to have. And so they weren't covered. And that was because they were pre-existing conditions. And they were things like, well, I had high cholesterol, so they didn't cover a heart attack. And then I had an eye problem, so they didn't cover that problem. And then I had something going on in my gut, so they didn't cover colon cancer. Not that I had any of those things, but if I did, they wouldn't be covered. And yet it was an expensive policy with about a $3,000 deductible. So it was really not good. But nevertheless, now under Obamacare, they couldn't do that. They would have to cover everything. So that's a benefit, right? And so subsidized, the other thing that Obamacare did is the subsidized private insurance for individuals. The premiums would be much too high for most people if it wasn't for the subsidies. Unfortunately, the subsidized program is not the good one. The good one is still unsubsidized. So what are the faults of Obamacare? One, it has not controlled costs or reduced financial stress. The costs, as you may know, the United States spends more on health care than any other country in the world, and specifically more than the other wealthy countries of the world. And so while we're spending like $14,000 per person per year on health care, all of the expenses together, other rich countries in Western Europe, Japan, Korea, Canada, they're spending like $7,000 to $9,000 a year. Well, how are they doing that? By having universal Medicare for all. The other thing is they've added a whole lot of complexity and confusion. They had to hire a bunch of people called navigators in order so that you could figure out what you needed to buy in Obamacare. So this adds to the bureaucracy, it adds to the cost, and then you're still not too sure. I tried to buy an ACA, just as a test, and I found it really difficult. And I've been doing this crap for like 15 years, so you can imagine it. So that's another problem. And then the third problem is it strengthened the private insurance industry by providing millions of new customers. And that's a bad thing for us because when they're strengthened, they can corrupt our legislators, which they do regularly. So Obamacare was what we call piecemeal change. And the problem with piecemeal change is our system or non-system is so complicated. There's so many payers. I said there's Medicaid, there's Medicare, which has private and public. There's private insurance, which there are hundreds and hundreds and hundreds of different private insurance policies. Nobody can know them all. There's the VA, there's the Indian Health Service. There's so many different possibilities. Again, it's terribly confusing, and it's very, very difficult to straighten that non-system out. It's a mess. Yes. Well, we'll wait. We'll take some questions as soon as I'm done. Let's talk a little bit. I want to talk a little bit about racial inequity in health, in our health care system. There's economic and racial inequities and structural factors that cause great variation in health outcome. And Dr. David Ansel, who was a doctor at Rush, said 4 stops on the blue line and life expectancy plummets. So you can't see this. It's too bad you can't see this. But anyway, it shows the people live in the loop have a lifespan of about 85 years. You go a couple miles to the west to East Garfield Park, it drops down to 72. Go a little further to the west to West Garfield Park, it drops down to 69. And then keep going on the blue line to Oak Park, and life expectancy it rises again to 81. So there's an amazing amount of health inequities.
They have a lot of murders going on.
Okay, one fool at a time, because
Yes, that does factor into it, but it's not the only thing. It's not the only thing. There would still be huge inequities, even if the murder rates were the same. The other big crisis in American healthcare is maternal mortality. More women die in childbirth in the United States than in any other wealthy country in the world. And the death rates are really astounding. We have 100 out of 100,000 live births in Switzerland. Only one woman dies. In Germany, it's 3.5, and in Canada, where they have a health a Medicare for all system, it's 8.4 women mortality out of 100,000 live births.
And what is it in the U.S.?
What's that?
What is it in the U.S.?
I'm getting to that next.
Sorry.
That's my next point. In the United States, overall, it's 23 so it's more than twice most other Western European countries and Korea and Japan too, about 4 times more. And that includes everything. But what's also strange is the breakdown by ethnic and racial group. There's a big variation. Hispanic among Hispanic women, about 17 per 100,000. Among white, it's a little higher, 19 per 100,000. But among blacks, it's very high, about 50. So we have this crisis. How is you might be asking yourself, what is single payer going to do to stop that? Well, for one thing, people of color are more likely to be uninsured and underinsured than white people. In Chicago, there's about 250,000 uninsured people between the ages of 18 and 64. Most of them are people of color. Under Medicare for All, everybody's covered, cradle to grave. So the whole problem of getting access to health care falls away. There is no problem anymore. It'd be hard to avoid getting health care. People of color are more likely to die from preventable and treatable illnesses. And also poor people of any color. And why is that? Because of the upfront costs that we have. The deductibles. Deductibles are really getting high. $2,000, it's almost up to $2,000 per person. So if you get sick, you go to the doctor, you go to the hospital, the first $2,000 you have to pay, in addition to your premiums, in addition to any co-pays. And that's a big deterrent to go getting treatment. Because who wants to go to the doctor in the hospital and spend $2,000 because you have a pain in your chest, and then you find out it's acid indigestion, and they tell you to take a couple Tums. You just spent $2,000 for nothing. So that's a big deterrent to getting access to care. Another problem is the fewer healthcare facilities. Existing facilities are not like in the neighborhood hospitals. Rural hospitals are closing because they predominantly treat people on Medicaid, and Medicaid pays the least amount for any service. Medicare pays the middle amount, and some private employers pay the highest amount. So if three of us went to the hospital with the same condition exactly, saw the same doctor, got the same tests, got the same treatment and the same prescriptions, the hospitals and the doctors would be paid, for me, the Medicaid patient, would be paid the least. And be paid a middle amount, let's say $3,000. And then for a middle amount, for a Medicare patient, they would get paid $4,000 or $4,500. And then for a private employer, they might be paid insurance, they might be paid $6,000. So the hospitals want to get they're incentivized to not have so many Medicaid patients and have more, the higher paying patients. And this causes a lot. Some hospitals that can't attract those kind of patients, they go under because they can't exist on Medicaid reimbursements. All of that will go away under Medicare for All because all providers will be paid the same amount for equal care. Okay, universal health care. Medicare for All is a universal program. It treats everybody. There's no exceptions. And I want to tell you about, it's a chart we can't see now, but I'm gonna try to explain it to you. There's a chart that shows longevity, a comparison of longevity between Black and white populations. And the chart shows from 18 to about 82 or 83. And the chart shows that these two lines begin to separate, and the white population has a longevity of about 6 to 8 years more than the Black population. And it continues to grow slowly all the way up to age 64. Then at age 65, something happens. The space between the two lines begins to come together. And as you go out to the low 60s and high upper 60s and lower 70s, they actually come together. And if you go up further, the Black longevity line actually goes a little bit ahead of the white longevity line. So what happens at age 65 that might make this difference? Medicare, universal health care. You win. And we think that the same thing would happen for the entire population when improved Medicare for All is enacted. Okay, so how are we going to stop the profiteering of the insurance companies? They're in the business to make money. They spend billions of dollars buying back their own stock, dividends for their stockholders, paying their executives multi-million dollars. How are we going to stop that? Well, by eliminating the private insurance company for the most part. They're going to be minor players. Instead of running the show, they will be minor players because it'll be, there's a bill in will be introduced in Congress. It will make it illegal for insurers to duplicate single payer coverage. So the only thing the insurance companies can do is the things that aren't covered by single payer, and that's going to be mainly cosmetic surgery and a couple other small things. So they'll no longer be in the market. They'll no longer be involved. They'll be relegated to a minor role. And what will this do? It will reduce bureaucracy. But let's go in and see how will single payer control costs? It's going to negotiate prices with the providers at the beginning of the year for everything. So there's one hospital can't charge $10,000 for a procedure, and another hospital charge $3,000 for the same procedure. They'll all charge the negotiated price, which will be obviously somewhere between the 3 and the 10,000. There'll be global budgets for hospitals and clinics. Today, if you've ever seen the bill from a hospital, it goes on for pages and pages. Everything is itemized, the Band-Aid, the injections, the visits by the nurses, and it's just a huge long list of things. That will be gone. And to do that requires an army of people in the billing department. That will be gone under Medicare for All. What they'll do is they'll say, Charlie, last year your hospital spent $200 million. So this year we're going to give you $210 million. You decide how to spend that money. And so there won't be this army of people in the billing department. There was a study done a couple years ago, maybe 3, 4, 5 years ago, and they compared a 900-bed hospital in Montreal with a 900-bed hospital in Rochester, New York. Montreal, Canada has a Medicare for All program. So in the billing department in Montreal, there were 16 people working. In the billing department in Rochester, there were 96 people. 96 people, and that all goes into the total cost of healthcare in this country. Things will be simplified. For instance, there'll be no need to police the people on Medicaid because Medicaid will be gone. Everybody will be covered by Medicare for All. And right now, if you're on Medicaid, you have to go through something called redetermination every year, which means you have to prove that you're not making too much money. So let's say you're a household of 3, you should not be making more than, the household should not get an income of more than $32,000. Well, you got to prove that you're not making more than that. Because if you're making $33,000, you're rich, you don't need public assistance. All of the people who are involved in policing Medicare redeterminations, their jobs will be redundant. However, and then of course there'll be a reduced need for people to handle denial inquiries and private approval requests, because there won't be that many denials and prior approvals. So, and then finally, corporate profits, dividends, and stock buybacks will be almost totally eliminated as part of the healthcare. Right now, they're considered part of the healthcare cost. It's pretty complicated. I know it's a lot of information to throw at people, and but there are some fightbacks. What is our organization doing? Illinois Single Payer has what we call a resolution campaign. Illinois Cities for Single Payer. We were trying to get city councils around Illinois to pass a resolution in support of improved Medicare for All. And then once we pass that, we're going to tell our congressional representatives to sign on to the new Medicare for All bill in Congress. This is part of a national effort led by Public Citizen. And
It's getting empty, man.
okay.
Go ahead, keep going, sorry.
And Public Citizen is a Ralph Nader organization. Yes, Ralph is still around. He's at 80-some years old, but he's still kicking. The benefits of this resolution program will build grassroots support and educate local legislators and gain media attention. But it's also an opportunity for us to educate our legislators about Medicare for all. And finding that to be the most useful thing. So Chicago has 50 alderpersons, so that means in order to pass this resolution in the city council, we need 26 alder people. And so far we have 11 have signed on. And I think within the next few months, we'll probably get that up to near 20. So we're getting close.
21?
20 city council members who support our resolution.
But why do you only need 20?
What's that?
There's 50 members. Why do you only need 20?
26. We need
Oh.
26. We've got 11 now. We need, the reason I say I think we'll get 20 is because the chairman of one of the committees, the health committee, which would be the one that would be considering this resolution, said she will get everybody on her committee to sign up for it. And that will bring us up to 20. Okay. There's a group called the National Nurses United. I don't know if you've ever heard of it. NNU, it's the biggest nurses union in the country. And they are real dedicated, progressive people. They have a campaign to build support for the new Medicare for All bill, which will be introduced in Congress at the end of April. The previous bill had 114 Democrats out of 213 signed on as co-sponsors. So their goal is to get all 114 to sign on to the new bill as soon as possible. And they need to do this in order to show some strength to reluctant congressional people and the media, and also to push back against Trump's threatened cuts to Medicare and Medicaid. So we want to be able to say to Trump, not only do we not want you to cut anything, we want you to pass Medicare for all. He's not going to do it, but we know that Medicare for all is popular with the general population. Every survey shows that a majority of people, once they understand what we're talking about, are in favor of it. There's some other group here in Chicago. It's called the Physicians for a National Health Program. They're a group of physicians, 25,000 physicians who support Medicare for all and do a lot of good work. They are leading the fight to stop privatization for Medicare, our current Medicare. And let's see, there's some other groups too, but I'm probably too many to go into without. So if you want to get involved, what you can do is join Illinois Single Payer Coalition, and I've got some sign-up sheets here so that you can lobby your older person to support the resolution. What wards do you folks live in?
33rd, Rosanna Rodriguez.
She's one of our greatest supporters. And do you like her personally?
Oh yeah, she's very open to she's very available to her constituents.
Yeah, she is the head of the health committee that I was talking about, and she's our hero. What can I say? Hello, yes.
49th Maria Haddon.
Okay, she's another supporter. As you might, you're probably not surprised. Yeah.
Algonquin and McHenry County.
Oh, you're okay. Well, what we need you to do is to go to your city council. What is it? What town are you in?
Algonquin, Illinois.
Algonquin, and see if you can get them to pass a resolution. That's a big job. I know.
I'm in the 39th, Nugent.
39th, Nugent. We don't have anybody there. Well, all we do with here in the city is we get somebody from the ward to make the appointment, because it's easier if you're from the ward to make an appointment with an older person than it is if you're outsider, and it's almost like a foreign country. So you need to, once we get then we go and do the presentation and give them the information, and once they say yes to an appointment, it's pretty much sure that they're going to sign up. So far, that's the way it's gone. But I'll pass around the sign-up sheet if you're interested.
I'm in the 50th ward.
The 50. That's Silverstein, is it?
Yeah,
I don't know. She could be a tough nut.
yeah.
She might be a tough nut. I don't know if she's But it'd be great but it'd be great to do it anyway. I'd be happy to make a presentation to her if we could get an appointment. She probably wouldn't give me an appointment, but she might give you. Do you know her? Have you ever gone to and spoken with her? No. Okay, no problem. We're asking people what ward they're in. What ward are you in Chicago?
No,
Oh, okay. What city?
Huntley,
Huntland. Oh, that's
but Kane County.
yeah. Okay. Wow, that's a long way to come, huh? Whew. Yes, and that,
Everybody's new in my,
a little bit louder.
everybody is a new alderman. We had, Connie, we had, the other guy. Yeah, well,
Who's your alderman now?
I did, some girl, Alan or some, I don't know.
Oh, okay.
It's on Broadway and Wilson.
Yeah. Okay. Well, what I'm going to do is I'm going to pass around a sign-up sheet. If you want to get involved or just be a member of the Illinois Single Payer, that's fine. Just sign up, and we'll put your name on the mailing list. If you want to be active, I'll get in contact with you, and we'll talk about ways that you can be active. But it'd be primarily with setting an appointment with your older person, or the other thing to do is we have the Medicare for All bill is going to be introduced into Congress the end of April. And what we want to do then is flood the Congress people, the Illinois congressional delegation, with calls and asking them to sign on to this bill right away. Now, every Chicago congressional rep, there's 7 of them who have a part of their district is Chicago. All of them have signed on to the old one. But none of the Democrats on the in the suburban or downstate areas have. So they're pretty good targets for us. And we'd like to at least get a meeting with them and ask them to sign on. Particularly some people like Underwood. Well, I don't know if you're from Underwood. So you said you're in Huntley?
Yes.
Yeah, I don't know. I have to look that up.
It's near Algonquin too, but it's voter came in the country.
Do you know who the congressperson is?
No,
Raja is mine. It was
Raja.
Underwood, but now it's Raja.
Okay, Raja. Now he hasn't signed on either, and he tries to present himself as a pretty progressive guy, but I don't know why he wouldn't sign on to this.
What about Bill Foster?
No, he hasn't signed on either, and I would say, he's very business oriented, so he's going to be supportive of the health insurance companies.
But he's a Democrat too.
And well, the Democratic Party leadership of the party is against this because of the money. Because they get so much money from the health insurance. I mean, it's hundreds of millions of dollars.
Well, that corruption. Washington.
Well, not in this country. In other countries, they call it corruption, but in this country, it's called the system.
We're gonna find out the 500 guys in Washington DC are.
Yeah, I mean, the amounts of money that they give to these, and to all of them. I mean, all across the country, all at the congressional level and at the state level. So it's probably over $1 billion, and the party won't give that up unless they're really, really forced to, or unless they lose everything, which they seem to be on the road to doing. So, any other questions? I'm happy to. Let's see. Let's start with you right here in front.
Yeah, you said that most of these other countries have a nationalized system. I believe they don't. They have 2 tiers. There's also a privatized system in many of them.
And small. Well, it varies from country to country, but they all have universal systems. There are no uninsured people, and there are no very, very few. And in countries that still have privatized systems like Germany and Switzerland, they're highly regulated by the government. The government tells them what they can charge. And at one point in Switzerland, I don't know if this is still true, the insurance companies had to pool their profits. So if one got a lot of profit, the other one got the other profit. They had to pool it together so that everybody had the same. I can't imagine that happening in America.
And I believe in Canada, but they actually own the hospitals.
They may own some of them. I don't think they own them all.
That-
In England, they do. In
Well,
Italy,
in
they
England, you have, in England, you have the NHS, and then you have private hospitals.
do. And you have some private. You know, the government is trying to privatize the system in England. They've been trying to do that
And-
for 10 years.
I know that the King and Kate sure didn't go to the National Health Service.
Oh, good for them. I like that. Okay, I'm gonna move on. Yes, right here.
How would you handle the unemployment if everybody at United Healthcare, Blue Cross Blue Shield, Health Service, Healthcare Service Corporation, lost their jobs?
Excellent question. There's money and quite a bit of money in the bills for retraining people to become healthcare providers at all different levels. So that's one thing. The other thing is we'll still need some Blue Cross Blue Shield workers to handle the bureaucracy of they won't all be government workers. And so there'll be some that were still used. But there may be some people whose jobs become, they can't be retrained as healthcare providers. And those people will probably, in addition to retraining, there's also, severance. There's money in the bill for severance to people who, it's pretty substantial. It's like half a year.
Severance, did you say?
What?
Did you say severance?
Severance, yeah.
For
people who lose their job because of this bill. Because, better to put the money into actually making healthcare than to put the money into the bureaucracy of healthcare, right? So, all right, you had a question here. What's your name? I shouldn't ask you.
I'm Jan.
Jan, okay, hi Jan.
The system you described is not what I understood, because I'm on Medicare. And Medicare sends out, okay, this is what we pay for this procedure. And anything above that, I would be responsible for. And this is Medicare, it's not Medicare Advantage. It's not Medicare Advantage, it's Medicare. And then I also buy a supplement insurance. So I'm paying for Medicare out of Social Security. And then part of my Social Security check goes to a supplement. But what you described, you said Medicare pays for everything, and that's not true. Medicare sets up what it will pay for. And then my insurance company pays the rest.
Well, again, Medicare, for some reason, pays 80% of what they approve, right? Is that what you're
They
saying?
pay 80% of what they approve.
Of what they approve. And then that's why we have to buy a supplemental. I'm in the same situation.
Part B, they put in supplemental.
Yes, and the supplemental picks up the 20%. But I have these injections in my eye because of macular degeneration in this eye. And I've had them and I've never paid anything. But I get the same summary you're talking about. And it's kind of crazy because it says what the hospital charged. And the hospital will say like $3,000.
Oh, yeah.
And then Medicare approved $250.
Yeah.
And then they paid 80% of that. And then so are you saying you're paying?
Whoever just walked into the mute, please.
Are you paying anything out of pocket after your supplement? Okay.
No, but I pay a huge, I pay for Medicare out of my Social Security.
Yes.
And I pay for a supplement, which is, I think, $400 a month.
Wow, that's a lot.
I'm not sure what it is. I don't pay.
I'm paying about 190.
And I wonder if you mind talking about, again, those two lines that come together after 65.
Yes.
Describe that, and I missed the start. I didn't understand that.
Okay, the lines are longevity, comparing longevity of Black people to white people in this country.
Oh, okay, I did it.
So, and I just want to say that under when we say Medicare for all, we should say improved Medicare for all, where we get rid of these. Medicare will pay 100% of the bill. It will not pay just 80% of the bill. I can't understand how that was ever passed that way, but I guess, I'm gonna go to the gentleman behind you.
Stay with me.
What's that?
I had a doctor that I really, well, yeah, but I'm almost done. I had a doctor that was really a good doctor, and he went concierge.
Oh.
So you pay him $3,000 or $5,000 a year, and he's on call for anything. But I couldn't afford that.
Yeah, I've heard of that. I've never, no, that's not good. Okay, the gentleman in the back, your name?
We've got 3 questioners waiting on Zoom.
Okay, I can't see you, so why don't you go ahead and ask questions?
All right, Calvin.
All right, we've got 2 more questions in here, and then we'll go to Zoom.
Okay, go ahead.
Go ahead.
Okay,
Loud, though.
yeah. I'm on Medicare. I get a bill. Maybe it's $300 from the clinic. Medicare says, okay, $300. Medicare over here says approved amount $250. They pay 10%. Why are they paying 10% of the $250?
10%.
Yeah, they pay 10%.
Never heard of that.
They never pay 80.
So they
Never.
negotiate down, you're saying?
So what do you end up paying?
I pay sometimes nothing, usually nothing.
Somebody's paying the $250. I don't know.
No.
Well, no, I
Blue Cross and Blue Shield pays like another 10%. So the clinic gets maybe half of what they bill for. And they're
well, that they all do that. They all give you this outrageous. I mean, I get out when I had my cataract surgery in my right eye at University of Chicago. I got the summary. The summary said what the hospital charged, $23,000. What Medicare approved, $2,800, 12%, and then they paid 80% of that, and the supplemental. That's been my experience, and so far I've paid nothing. I'm going to go on to this gentleman here.
I just want to say Obama and the Democrats, especially the progressives, want to fundamentally change this country into socialism.
Yeah.
Yeah.
They want to bankrupt this country.
We're already going bankrupt.
Well, every man, woman, and child in this country are going to be under Medicare.
Yep.
That's going to bankrupt the country, and that's what they want.
No.
Yes, they
Medicare
do.
will be Medicare for all will be cheaper than what we have now because the profit motive will be out.
We're
Not entitled to, we paid for it. I paid for my Medicare.
I
I
paid-
paid for my Social Security.
Right.
I paid for
These
it
are-
decades ago.
These are earned benefits.
It's not an
Earned
entitlement,
benefits.
it's something
That's all these deadbeats. They want to. How about the illegal aliens? Are they going to get it? I'm sure.
All
they are.
residents of the country. So it'll be up to some other agency to make sure they're ready. So we have some questions online. Let's see.
Taxing the billionaire.
How do we
All
do
right,
that?
let's go to online now.
Hi. Yeah, I don't know if you know me. I'm Calvin. I live in Liverpool in England. So I live under universal healthcare. And I do apologize. I come a little bit late to your lecture. In your presentation, did you mention the business reasons for universal healthcare? America is one of the only one out of 49 top industrial and Western nations that do not have some form of universal healthcare. And the reason for this, the reason why the other 49 choose this system is for honest to goodness business reasons. If you're if you own a business owner, so we say, making widgets, and you have 250 employees, and you've got an R&D department, HR department, a marketing department, manufacturing, etc., etc. Why the hell should you be bothered trying to choose what health insurance for your employees? It's not something you need to be worried about. There are other health benefits. A healthy workforce is an efficient workforce. You don't want, all of these things. There are 10 good, solid business. You said there was a politician there that's business orientated. If he really was business orientated, he'd take up your Medicare for all tomorrow.
Okay.
It makes sound business sense. Do you think Germany? I'm talking to the speaker in the room there. Do you think that Germany is some rabid socialist place? Do you think Japan is some rabid socialist utopia? Really? Honestly? You think the most industrialized nation in Europe
Okay, next
is socialist?
Have you ever tried to make a pro-business question or explain why Medicare for all would be good for businesses, good for corporations?
We haven't found many audiences that wanted to hear that. But yes, for the small business, it would be wonderful because they no longer have to provide health care to their employees. And if they don't currently provide health care for their employees, then they're at a competitive disadvantage when they try to hire somebody. Because who wants to work for a company where there's no health care?
Have you ever tried to make an argument that GM would be better off, General Motors would be better off with single-payer health care?
Yes, we have. We have tried to make that. In fact, at one point, there was an event where General Motors moved a plant to Canada specifically to save that money, and then they got criticized by their other business.
Yeah.
There's another thing. This country is very, very under the control of business ideology.
Here's another business thing. Okay, Walter White, right, lives in a country with universal health care, right? You know Walter White, Breaking Bad. Right,
Sir, we got to move on to another questioner.
Okay, what happens if you've got universal health care? He then takes another job as a chemist. He doesn't have to take a job as a high school teacher. He can take a job as a chemist. His cancer's sorted. His wife's pregnancy's taken care of. He then goes on and invents something else that makes the country a fortune. There's a business idea for you.
All right, Joe Coptic.
Some questions. Broken technology.
Joe Coptic, please.
The speaker mentioned something about universal health care not covering cosmetic procedures. Bear with me for a sec. This is kind of an elaborate question, but I just want to be thorough so you understand what I'm asking. Who would define like cosmetic versus, who would decide what's medically necessary procedures? Because there's a lot of very controversial treatments that even ones that people would consider as causing death and don't want to pay for, like euthanasia in Canada, abortion, you could say causes death. Reactive vaccines. What if I just am not worried that getting rid of the profit incentive is going to solve all these problems and I just don't want to pay for it? Like, would you be satisfied if 50-60% of Americans were covered by the program, or what? Would there be exceptions?
I don't know what the bill says about that, but I do know that when we say coverage, the coverage will be determined by a body that consists of representatives of doctors, hospitals, clinics, drug companies, some politicians, and probably a few professors. And what they come up with, I can't predict at this point, but we will know what they cover specifically. Every doctor will know. It'll be unlike today where you just have to guess what's covered and what's not covered. So I don't know. A few more questions, shall we?
Yeah, on the telephone.
Oh, God, why you got Zoom on?
6157.
When I lose my Blue Cross and Medicare coverage.
I thought we were on the Zoom. George.
Yes.
Go ahead. Yes, you would.
Telephone caller.
No Zoom tonight for the rest of the night. Shut up, Mike.
Okay, go ahead.
Well, that's what I'm saying.
Shut up, Mike.
Very good insurance. I don't pay anything usually.
Hey, we've got a telephone caller.
I'm going to get an inferior Medicare Advantage, is it? What do they call that? Medicare Advantage? I heard bad things about that. You don't even have it. You got Medicare Traditional.
I don't want you to have Medicare Advantage. I want you to have improved Medicare for all, which is not in existence yet. Okay, so are there any more questions from somebody who hasn't asked a question yet?
Yes, we've got one on phone, but he's got to unmute. Unmute your phone.
Okay, Charlie, go ahead. Anybody else?
Okay,
can you hear me? Can you hear me? Okay. My question is, thank you for your talk. My question is, who's going to control the system from the top? Who's going to decide what is legitimate and what isn't, what's covered, what isn't, and so forth? And by legitimate, I mean.
All right, that's a good question. Who does it now? Who decides for Medicare and Medicaid what's covered and what's not covered?
Well, the insurance companies, but that's beside the point. I'm asking if you got to say, in the Canadian system, who makes these decisions?
Well, they have a board. No, Medicare has a board right now that has a board made up of doctors and representative doctors and hospitals and some politicians, and they decide what Medicare or Medicare Advantage covers. All right, the insurance companies don't do that. The insurance companies decide who they're going to cover, but not what they're going to cover. Okay, so the same thing will happen under Improved Medicare for All. Except there'll be more representation from the healthcare workers than there are from corporations. So that won't be too much different than what we have today.
I got a question.
The gentleman in the back, and then we'll come.
Well, I got a follow-up question. If that's the case, how do you ensure that the requests are legitimate and not coming from someone who's trying to pull fraud on you? There is a certain amount of fraud in the current system.
Decide that. We can't decide that.
If they put in the code for the operation, they go, no, we don't cover that code. You're not going to get paid.
Exactly.
Done.
Right.
Because it just happened to me.
Thank you very much.
I got a question. I have an question.
Mike.
Okay, so I've been on Medicare a couple of years. And I've been on Medicaid. I tried it out for a year or two. I should have tried it before. Medicaid is for income based. Now here's my understanding. You tell me if I'm right.
Go ahead.
Medicaid is income based. So poor people like under 20 or 30,000 a year, something like that, they cover everything. That's
Pretty
Medicaid. Medicare for all. Medicaid is Medicare for all for low income. Okay, Medicare, if you get part A and B, which equals C, means that it covers everything, but I gotta pay like $2,500 a year for that, $200 a month. Medicare C covers everything, but it doesn't cover pharmacy, eyeglasses, dental. Medicaid will, and that's about it, folks. Medicare covers everybody because I paid for Medicare.
What's your question?
Well,
Were you listening? I said I want to run it by him and see if it's correct. My understanding. Medicare pays for everything. Part A, Part B, Part C. Part D is prescriptions.
Right.
Oh, right.
Right.
So I got this right.
Medicaid pays it pays for more things than Medicare does. Like it pays for long-term care, but it pays a minimum.
No, Medicare pays for long-term care,
but just for a short period of time. If you're going to be if you're going to be permanently in a long-term care facility, Medicaid is the only public source of money, and
that's SNAP, and it's eye care, and it's dental.
No,
Yeah.
SNAP is not Medicaid.
That's something else. Okay, so Medicaid is eye care, dental.
The problem with Medicaid, it pays very little. It's hard to get specialists to take Medicaid patients, particularly outside of the big cities. It's very hard for people to get. They have to travel sometimes 20, 30 miles to specialists.
Yeah.
Because they're really, I mean, a lot of doctors just lose money on Medicaid patients.
But let me say, I'm happy with the way Medicare works. I understand it's a big bureaucracy, but you gotta have that.
Sure.
And I'm happy with how Medicaid works, although I think I got kicked off of it because I make too much money now. And so now I'm off. But for lower income, Medicaid's wonderful.
I agree.
Okay, so
Next question, the lady behind.
Yeah, I have a question.
All right, Charlie, go ahead.
Bill, why is it every employer in the United States is not obligated, if they want to hire someone to do work Why are they not required to provide a health care benefit to each and every employee by law?
Because this is the United States of America and it's controlled by business interests and they don't want to do that.
They just don't want to do it?
It's a political issue, yes.
Okay.
It's politics. The lady behind in the blue, yes.
Okay, so with this Medicare for all, I mean, right now, people pay, a premium, when, a premium payment when they're on Medicare. I'm on Obamacare because I don't have an employer who pays, but I mean, I am being paid, I'm being charged like $471 a month just because I want to be able, because I'm not young anymore, and I want to be able to choose the doctors and get the health care that I need.
Sure.
So I'm just wondering, you know, I'm not necessarily opposed to people who are wealthy paying more, but are you saying that no one would have premiums and co-pays?
Correct. That's the way it works in most countries. You know, and to a certain extent, it's like the fire department. You don't pay when the fire department comes and, you know, puts a fire out. But we pay through our taxes. So the payments will come through the taxes. But the whole system will be costing less. So some of us will find that it's a huge savings. So, but there will be no Medicaid or ACA under improved Medicare for all. One system with one standard of care for everyone.
So with cost, there should be a restructuring of how doctors are paid, because I know they're paid differently in the UK.
Well, they'll be paid the way they're paid through Medicare right now.
Per procedure.
They'll send the bill to the Medicare, approved Medicare for all agency, and the agency will pay them.
Okay, we're gonna have to go to rebuttal, so this will be our last question. Anybody on Zoom yet that hasn't asked a question?
I think
Okay.
all the doctors are required.
All right, that's our last question. We're going to rebuttals after this.
Now, the agency that really would this fall under, wouldn't it be Health and Human Services
Well, yeah,
under RFK Jr.?
yeah, that's a problem. There's no question about that. Yeah, the people Trump put in there have no business being in there. They have no experience in this area. They've never run anything. He put them in there so he could control them. Because he thinks he made a mistake last time when he was in office by putting in good, people with some experience. But now he wants people that know nothing and he can just tell them what to do. And he has better control over the entire government. So,
All right, we're going to go to rebuttals now. If you have a rebuttal, I needed you to get up to the podium and speak. If you're online,
I'm going to take this away.
it's fine. George is going to go
Wait,
first.
Can we thank our speaker?
Yeah, let's thank our speaker too. Thank you for the reminder. All right. Going to give everybody about self-regulate to 3 or 4 minutes each, please. Go ahead.
In 1983, Columbia University classmate of Barack Obama tells about the plan to destroy America, the plan. Campus radicals were obsessed with hatred of America. They wanted to turn America into a socialist, Marxist, communist country. Obama was a communist. He was taught in Hawaii from this famous communist taught him when he was a young man. Columbia is still a radical university. The plan is to get everyone. That's the plan, is to get everyone possible in America on welfare or Medicare for all. Yeah, Medicare for all, every man, woman, and child. Food stamps and 100 other government welfare programs. It's so many on the government dole that the economy is overwhelmed, destroyed, collapses under the weight of the exploding national debt. We got $37 trillion growing. This country's going bankrupt. Medicare for all, you kidding me? Basically, America goes bankrupt. because of the collapse of the economy and society, America should be ready for socialism, bailouts and a permanent welfare state and a monthly universal. In Chicago, they're giving people $5,000 a month just for being there. We got 50,000 illegals in Chicago, and we're paying for their health care and their maintenance, everything. The radicals have updated the plan. They want to open the border and invite the whole world in. Every country, 150 countries are coming in, these people. They want to fundamentally change America forever. President Obama has said many times he wants to fundamentally change. He's the one behind Biden. He's the one behind Biden is Obama. He's the one making these decisions. And he's the one trying to bankrupt America so that it becomes socialist. So he got, how many mansions does that guy got? President Trump wants to end illegal immigration and make America great again, he says. Okay, I personally have reservations about some of Trump's agenda. That's it.
Next rebuttal. Did Jan leave?
I don't know.
Find your petition.
Just a quick one on the last one. Britain brought in universal healthcare in 1948 when we were absolutely broke. Don't believe it when you say you can't afford it.
Don't make me say you can't afford it. He's actually very much paper what you're saying.
1948, we still owed you guys for all that lead lease.
Next rebuttal.
Oh, okay, I'll say a couple of things.
Thank you.
Oh, the microphone's over here.
Just stay where you're at.
Oh, okay.
Speak there.
Okay, can you hear me?
Yes.
Okay. Hey, my name is Ellen. Yes, I do think it's a very unfair system. Right now, for example, there's a number of states that did not expand Medicaid. All those people who are poor but don't have children don't have any health insurance. Also, you know, there's a number of people, a lot of people who Medicaid is based on what the criteria is based on what you made in the last 30 days, your income in the last 30 days, while the marketplace insurance is based annually. So you can make too much money in the last 30 days and you don't qualify for Medicaid, but you don't make enough to qualify for the annual marketplace insurance. A lot of people are in this situation. It means they have to be dishonest to the marketplace insurance, and if they don't make enough money, they could potentially have to pay back many thousands of dollars to the marketplace insurance because they don't qualify for Medicaid and they don't qualify for marketplace either. But it's a stressful situation. I've been in that situation before. But yeah, I think healthcare should be a right. I'm not opposed to wealthier people paying more, but like, I not making a ton of money, but I am being charged $471 a month for premiums because I want to be able to see the doctors that I need to take care of my health needs. And the HMOs are pretty horrible. Often with the HMOs, I originally thought, oh, you could just go to your primary care physician and then they'll just let you go anywhere. They'll refer you to a doctor anywhere, but that's not the case at all. You have to go to your primary care physician and you have to find a doctor within that network, whether it's Advocate or Amita or Ascension. They change their name every other day. And so if you want to see doctors in different healthcare facilities, suppose you want to see someone at the University of Illinois at Chicago, you have to constantly be changing primary care physician.
Please.
What?
Jake, would you mute, please?
Yeah, you constantly have to be changing your primary care physician in order to get a specialist in the network. So that leads to a lot of extra unnecessary appointments and a lot of changing of primary care physicians, which is costly and overly burdensome. It's a lot of red tape. So it's not a good system. Thank you.
Okay, who's next? Charlie, are you online?
Yeah, I'll go next. All right, I'd like to thank Bill for coming out again. Sorry for some of the technical problems, everyone. And I want to thank the Illinois Single Payer Coalition for continuing to try to seek resolution on this issue. I have only 3 things to relate tonight. I won't keep you for long. George, you might want to know that I attended and I'm a graduate of Columbia University, like Obama. I don't think they brainwashed me while I was there. I think I got a solid academic education, but they seem to think that it's some sort of place where young people are inculcated with Marxist ideas. That's not really the case. I know you want to believe it, but or you're taught that by your handlers on the right. Okay, that's the first thing. Columbia's a good place. I highly recommend anyone seeking an education there. Number 2, the basic question is, people need health care. And how are we going to pay for it? And I hope you're listening, George. It just came out, the annual Forbes rating of the wealth of the world. And of the 3,000 billionaires, that's with a B, 900 of them are residents of the United States. Now, if you want to pay for anything, and I firmly believe that it is ethical under all circumstances in a condition of need to take from the rich and give to the poor. Now, if you want to have something financed, I think these 900 billionaires have more of the comforts than any person could conceivably want. And to make them, obligate them, and others of their station to pay for a basic human need as health care for every man, woman, and child, and all the illegal immigrants who wanted to, you could take the money from these people and they would experience little or no discomfort. There's plenty of finance out there. If you go looking to how to finance a particular piece of legislation, there's always the thing is, how much does it cost and are you going to fund it? You can fund it right there. Now, the last thing is, in the United States, beginning in the latter part of the 20th century, major unions negotiate contracts. And always in that contract was provision of health insurance. Now, what we've witnessed is a continued erosion of the ability of the unions to get that benefit from private employers. It has been eroding, and eroding at an alarming rate. They wanted to get out of business of providing a benefit. They did not care that the condition of your health was under any of their obligation whatsoever. Now, they started with two-tier systems, meaning new hires, for example, would get little or no insurance. And the unions had to agree to this in order to keep health insurance for the senior, those with seniority within the corporation. But it's gotten to the point, and we've let them get away with it. Now, I asked the speaker why his organization does not lobby for employers to provide health insurance. You work very hard to make some guy rich, and if you get old and you get sick, the way I feel, he says, well, thank you very much. I'll see you around sometime.
On your own, pal.
Now, I'd like the organization to add that to their legislative agenda, that we return the obligation, if you wish to hire someone in the United States, the condition of being able to employ somebody should be able to provide a basic benefit that they would be catered to if they become ill or unable to work. Somewhat like on-the-job injury. Anyhow, that's a very good thing. That's my take on it. Keep up the good work, Illinois Payer. We appreciate you coming. Please come back with an update on what's going on in what appears to be a volatile public policy. Thank you.
Okay, Mike, go ahead.
All right, thanks for sticking around for my rebuttal, everybody. It was an important topic. Thank you for coming here.
Yeah, but you're still wrong anyway.
It's too bad we had Zoom problems and a bad turnout today. We've had much worse speakers, not much, but worse, that we filled the whole room for. So I don't know what's going on tonight. Maybe a soccer game or something. I don't know. The Bundesliga. Anyway, this is an important topic, and I've had experience with Medicaid and Medicare, so I think I could speak up to it a bit. And I have an economics finance degree, so I know a little bit about money. Who has not been insured in their life for years? You've always been insured.
For the most part.
Well, yeah, I mean, I've had a couple of years where I didn't have any health insurance.
I've been insured through the VA for a while.
Oh, okay, that's another thing. So I've been uninsured for, when I was younger and healthier, so it happens. But my experience here is that I think we have Medicare, we basically have Medicare for all up to a certain income level. So Medicare Part A, B, and D, if you get pharmaceuticals. When I had Medicaid, they covered pharmaceuticals, but I think I got kicked off it recently. But I think we have Medicare for all basically if you're lower income between Medicare and Medicaid.
You're in the right state that expanded Medicaid.
Right, if you're in a hillbilly state that doesn't care.
It's called Mountain Williams, not hillbillies.
What do you call them?
Appalachian whites.
What, Mountain Williams?
Like red states that, don't want an anti-state, don't want to take care of their people. Illinois is a good state. It takes care of the people. They have a lot of benefits here. Taxes are higher, but, you get some goodies here. It's a good state. So, okay, move to Mississippi, Russ. Let me know how that goes for you. Or Louisiana or Idaho. Anyway, there's some bad states out there. Oh, we got low taxes, but we have nothing else. So between Medicaid or Medicare, I paid $2,500 a year for Medicare, A and B, and I had Medicaid, which eyeglasses, dental, other stuff, pharmaceuticals. That was nice, but I couldn't make too much money. But now I did one year now, and I'm kicked off. So I would think that they just have to
Expand, get rid of the income requirements.
on Medicaid.
Medicaid, yeah.
Something that simple would do it.
Put everybody on Medicaid. But you have to pay the providers more.
If you're making over a certain amount, if you're making $50,000 a year, you're going to have to pay $500 to be on Medicaid. But everything will be covered. No co-pays or anything else. That's basically what you have is a decent insurance program for $500 a month, right?
Yeah, but I'm making little money. I mean,
Well, what's little? It's a relative term.
over about if you make over about $1,243 a month, around that, they kick you off of Medicaid.
15,000.
Not a lot of money.
No, well then,
Depends on how big the household is.
Right.
yeah, the
One.
household size.
One.
Household of one, it's about less than 20,000 a year.
Yeah, less than 20.
So you're making over 20,000. So now you got kicked off of Medicaid. That's what happened to me. So it seems like that. And then there's people who just don't want to have insurance, or if you're young like I was,
They just can't afford it.
well, they want it, but if they're healthy, they're like, well, why should I spend $5,000 a year on insurance if I seem like I'm pretty healthy? So those are people that are uninsured. So I think it's a pretty good system. It probably should be raised Medicaid to cover, poorer people, 20, 25,000, have a scale. And then you're covered by.
If we could do that, we could get Medicare for all and do away with all the complexity and requirements, and everybody's covered with everything all the time.
Okay. That just increased Medicaid's income range.
Okay, are you done, Bill, or?
It's Joe, not Bill.
Mike.
That's so. Thanks for
Anybody else
coming.
online?
It was an important topic. Our technical people let us down. Zoom got
Stop it.
Zoom always gets in the way
How
somehow.
many people were on Zoom?
There's about 5 or 6.
Sometimes we
It's not too
get
bad,
10 or
but,
15, but
it does work. All right.
we should have had more people here.
Well, yeah, we should have, but we didn't. But we did get it recorded, and it's going to go up online. It's been pretty well taken care of. Thank God I was able to figure out a way to. All right, anyway, I'm going to do a quick rebuttal myself. Anybody else online? All right, go ahead and go.
Yeah, me.
All right, go ahead.
Okay. So first, to address some of the stuff George said, I mean, I think Trump is just as bad as most of the Democrats think he is, but I also think Obama is just as bad as George says he is, but for different reasons. I don't think Obama is a communist. I think he's a fascist. If he were a communist, he wouldn't be a Zionist. He wouldn't do all the deportations of immigrants that he did, and he wouldn't have asked Citibank and Wall Street to staff his cabinet for him. So he's a fascist. I agree we should, take for the rich and give to the poor, but only to the extent that those rich got rich by stealing from the poor. There is some level of merit in our system. It's not as high as a lot of the really staunch capitalists think there is, but we need to tax the right things, and that means taxing the waste of public revenue and the wasting of common lands, and not just tax people because they're rich. I think to address some of Ellen's points, I think not means testing would help And that's why I do think Medicare for all could save some money if you do it right. I'll clarify that in a sec. I also think that not taxing income in the first place would make it easier for us to stop caring how much people are making, so that we can remember we're all Americans. We are allowed to access these public programs. I think that would help the not means testing thing. My concern about all this is just I want to have consensual involvement, and there should be true medical necessity. Like when I hear it's going to cover everything for everyone all the time, that actually scares me, because like I have very little faith in the medical system in general. I'm not going to say there haven't been doctors who saved my life with antibiotics, but wondering if I would need those antibiotics so often if I weren't vaccinated a lot as a child, and probably at least 2 or 3 times as much as previous generations. And it's still legal to sterilize people because they're mentally unfit in a few states. So I don't think that is because of profit incentive. There's probably a lot of problems in the medical system caused by profit incentives. I don't think sterilizing people is one of them, because you'd want a productive workforce if the goal was to just control people. I'm also really concerned about how when people go into the hospital, it's just totally the doctor's decision now whether you need water or food or adequate clothing or heat in order to survive. Now nature and your needs don't determine that. A doctor gets to say, you're not allowed to drink that, you're not allowed to eat that, you're only allowed to have hospital food or something. You have to eat ice chips instead of water because you don't care enough to make sure your lips aren't dry. So there's people being ignored in hospitals, and I don't know if that's because of the profit incentive. And there's a lot of really crazy procedures out there now. There's something called breathwork therapy, where this guy just comes around and half suffocates you to death, like gets you on the ground and half suffocates you. So you go, and they call that therapy. Like there's insane people calling themselves doctors. I think we need to get the eugenics and the euthanasia out of the medical system before we start talking about making everybody pay for it and everyone be involved in it. I don't want to pay for abortions of people I've never met who live 5,000 miles away in Hawaii, for example. I'm not even pro-life. I don't think health is it's too controversial an issue, and especially with the transitioning minors and all the things they do to women when they're giving birth to make them induce as rapidly as possible. That could be profit incentive caused problem, but there's a lot of non-profit incentive caused problems, and I don't really appreciate the way doctors are kind of slapping themselves on the back, where you go to the doctor's office and it says heroes work here. It's like, I'm not allowed to talk. I'm not even allowed to tell you what's in the vaccines. I got my blog entry taken down for trying to tell people some of the ingredients have been in vaccines. So if we can't know what's in it, it can't be consensual. We need to respect consent to the governed. And if we can find a totally voluntary form of Medicare for all, I would consider it. Thanks for the presentation.
Okay, you want to go ahead.
First thing we must remember, the 9 deadliest words in the English language. I'm from the government and I'm here to help.
All right.
And second off, Medicare for all, it ain't. It's more like going to be the National Health Service.
All right. I can't look for it.
And anything you don't like about private health care, I think government health care is just as scary.
Okay. Anybody online?
Canada.
Anybody?
Remember this. Government isn't the solution. Government is the problem.
Yeah, for the rich.
All right, now, anybody
Famous
online?
president.
Hell then.
Rich don't
Come
want
on. Okay, the last speaker said it's all about that, you don't want government in your healthcare. The NHS is not government. It's a semi-autonomous body. It looks after itself. Government helps finance it, but it's mostly financed by your own health insurance, which you pay into, and it's a self-government. Do you know how much you're getting ripped off in your health? Right? Do you think Did you? This is what you're saying. Do you really think it costs $5,000 to fix a broken arm? Right? I'm listening to these people and they're saying it's $450 a month for health insurance. I just looked up how much private insurance costs in Britain when you've got the NHS as competition, right? And it's on the chat there. It's Bupa. And the average, not the lowest, the average cost of private health insurance in the UK, because you can get private insurance as well. You just can't opt out the NHS, right? The average cost is £50 for a single person and £220 for a family per month, right? Not $450. We're talking $70, $300 for a family. That's how much you're getting ripped off.
It's profit. All right, anybody else?
Jake, we got Jake.
All right, Jake, go ahead.
Unmute, Jake. He's muted.
Jake, unmute, please.
I'll go.
It was running 1,000 of them.
All right, Charlie, go ahead.
I just want to say that in the United States, it takes at least 12 years of secondary education to even think of practicing medicine. I am singularly amazed how some people think that 12 minutes of cruising the internet using Google, that they have the equivalent of a medical degree and come before an audience and make pronouncements of what they consider to be factual information. That is not the way you approach an area which perhaps is an area there's choices and decisions to be made. However, you are not the equivalent of a licensed medical practitioner. And please keep that in mind when you make your assertions. Thank you very much.
All right, anybody else? Okay. All right, anybody else? Because what we're going to do now is
Jake is ready.
Hi. Hello? Just quickly.
Yes, go.
Just quickly, the issue of euthanasia was brought up. Euthanasia is illegal. It should remain in the United States. It should remain illegal. I'm totally opposed to it. It's not a financial issue. It's a moral issue.
Okay, Jake, is anything else? Or is that it?
That's it.
All right, let's let our speaker get our last word in. If he just wants to thank us and wrap up, that's fine. If he has a few weak things to rebut everybody with, that's fine. So go ahead, sir, and
okay. I just want to clarify one thing about improved Medicare for all. When we have it is publicly financed, privately delivered. In other words, the doctors and the hospitals are still private and owned by whoever they're owned by. Well, unfortunately, it's headed toward hedge funds and private capital owning everything. So we'll all be working for them. Second thing is, if you object to this being controlled by the government, then please give up your Social Security, your Medicare, your Medicaid, and all those benefits because they're all run by the government, including the VA. So if you don't want the government in your life, give that up. And thank you very much for all your interesting comments. And I'll try to stay in touch.
All right.